seen by somebody, I think initially, make sure that we know at least what's not going on, so we can care. Now, I don't mean on the sideline, someone that hurts to walk. By the time we get to the locker room, they don't hurt anymore. I mean something that's persistent, that's lasting more than a day. And obviously, anything with any deformity, that's more urgent. Anything with any deformity, I'll usually send them that night or that evening. Our X-ray guidelines that we are supposed to follow, but I don't always, I'll admit it, is any bony pain. So these are one of the older rules that are out there. There's a bunch of guidelines for when you should X-ray an ankle and foot and when you shouldn't. But it basically comes down to any bony pain, especially along the medial or lateral malleolus, where the fractures are frequent, along the navicular bone or the base of the fifth metatarsal fracture. Again, those two, it's not a surgical injury. We take care of those. They get better quicker, and especially in the case of the navicular, but really in the case of any foot fracture in that part of the midfoot and the lateral midfoot, lateral and medial midfoot, we prevent chronic pain for the rest of their life. So what do we do if they're not painful injury? Well, when you suspect tibial stress injury, there's certain things to look for. Tibial stress injuries are going to be way more runners than anyone else versus an acute tibial fracture. We suspect it in anybody, whether an athlete or not, sudden change in activity. This will include for us in the office when we have somebody that was essentially didn't do anything all summer, or hadn't anything for months or years, and decides to start a program that can develop stress injury and stress fracture as quickly as 2 weeks of age. Definitely different risk factors come in that come into play for everybody. It can be, again, flexibility and weakness, the proprioception we talked about. It can be an orthopedic deformity they may have. It may be that they're training incorrectly. The most common one between excessive training, what the train is, and footwear we see as the footwear part. Most people that we're treating are footwear. And then as we get more into adults, you'll see a lot of people, especially if they don't have the money to go out and buy shoes. You'll see them in an inappropriate shoe just because they're trying to make one shoe do a bunch of stuff. The other thing is more medical. That's a lot harder for any of us in this room to control, including me, because we've medical status, or they need to get these evaluated. Do they have a thyroid problem? Vitamin D deficiencies are real common now that we're looking for them. I'll argue we just didn't know to look for them, and so forth. Anemic, especially in our female athletes. Those have. What they're trying to look at is, do a combination of risk factors lead to a higher risk? And for sure, what they see for a tibial stress injury is that lower muscle mass and a higher body fat, lower protective mechanisms at play seem to do it. The structure of their feet being flat-footed or high arch seems to have something to do with it. And the one that's hard for us to see is, do they have thinner or smaller bones, more petite athletes? There's not too many people that are big boned out there, by the way. There's no such thing. I have x-rays and MRIs. In our differential, we always look at the spectrum of a stress injury, which is at its mildest shin splint with this inflammation of the lining of the bone. Although you're always consider a calf strain. On the medial aspect of your tibia, it could be specifically a posterior tib strain. On the lateral aspect, behind the fibula, it can be a perineal strain. They'll have some on the ankle as well, even though it's not an ankle injury. Not all the time in our age group, a little bit more adults, but is it actually nerve involvement? A disc problem going on in the back that is occult and hidden. They don't have the classic injury or symptoms, especially in their exams complain of the same pain and the same things that aggravate it. So could their sciatic nerve be involved? So look for irritation. And always kind of the one lingering that I know we all think about is could it be compartment syndrome? With compartment syndrome, we don't know how common it is. Remember, in your upper extremity athletes, especially tennis, especially a thrower, a baseball pitcher seems to be the biggest one. It can occur in the arm, especially the forearm. Exertional compartment syndromes tend to occur in people that are young seem to be more at risk. There seems to be certain sports like lacrosse and field hockey that are at risk. Versus tibial stress injury or tibial bone injury, where a higher body fat, lower lean muscle mass may affect it. BMI is not a risk factor. Those are not risk factors for the compartment syndrome. And it's something to be suspicious of, especially if their pain's gradually increasing. If they complain, it sounds like they're complaining more about muscle than about bone pain. And especially if when running that involves it, they feel a lot better. So those are the things we're really suspicious for and so forth. The biggest part of this slide is the reproducibility is the main thing we want to look at. I will tell you that compartment syndrome is not common at all. I probably don't see even one case a year, even though when you throw shin splints and stress fractures of the tibia in there, you probably see 150 of those. But we're always suspicious of it if they're slow to get better. But what we want to see is that the pain begins within several minutes, not within 30 minutes, not after the workout or anything, of their activity that aggravates it. It steadily increases as they keep using it, and it resolves completely with rest within 20 minutes. My partners that take care of this and test for this will tell you that it usually rests within goes away within a few minutes. But as soon as you get that muscle better, especially if you're putting ice on it after a workout, without this pattern, and this pattern isn't specific, doesn't mean if you have this that you will have the compartment syndrome, but without the pattern of pain within several minutes, steadily increasing with the inciting event, and then completely resolving fairly quickly, they probably don't have a compartment syndrome. When do you refer them, whether they have this or it's a problem or not? Definitely when they're not responding to treatment, especially if you've been trying cross-training and other things. We talked about any pain with weight bearing, when the symptoms seem to be out of proportion to their history, they injured it or didn't injure it in their exam, especially with the compartment syndrome, and when they have increased pain and are failing to improve. Remember, what we always want to do with compartment syndrome is make sure it's not a muscle, which it commonly is, or a stress injury, which in our office, that's what it really usually is. So you'll see us do MRIs and bone scans first. Compartment syndrome isn't ruled out. We'll frustrate a lot of parents that way, but usually get a quick scan. X-rays are normal, get a scan, they're normal. They'll move on to some. We don't have to do a lot of surgeries on those, although we do enough of them. The other thing in the lower extremity, moving on down from the tibia, is it could be an acute rupture or rupturing, other than playing basketball or sports, is really uncommon under 40, which means most of you, especially men in here, are at risk, and you know who you are. Under 25 years old, it's all unheard of. You could almost write a case study on each one, other than they have the direct blow. Achilles tear I've ever seen under 25. The kid was about 15, 16. An athlete, I forget at what high school, this has been 1,000 years ago, but a cattle gate swung around and hit him in the back of the Achilles, literally cut it in half, without doing a lot of damage other than scraping his skin. That's the only one I've ever seen. And I still didn't believe, I thought I was wrong on my exam when I sent him for the MRI. I still didn't believe it. Where irritation and inflammation of the lining, kids are more likely to get a true tendonitis. Sometimes you'll get bursitis. The bursa is located in that little corner tucked away between the Achilles tendon and the heel or the calcaneus on this diagram. More often, especially 14, 15, and younger, or if you take care of any middle schoolers, really to 8th, 7th, to 9th grade, you'll see what's called disease, which is an inflammation of the growth plate of the back of the heel. I picked this illustration because it really shows that well. That's real common with or without injury, usually without. It has to do a lot with activity, inflexibility, a little bit with strength, but what we really see it with is surface, worn out shoe. Years ago when our drought was real bad and all our grass fields for football and soccer were turning into concrete, I saw a ton of this. Dirt with cleats on hard dirt. Plantar fasciitis can also occur. Plantar fasciitis is really, really, really uncommon in this age group. they're much more likely to have Seaver's disease or some kind of stress injury to the Achilles. There's a little diagram of an Achilles tear looks like on MRI. White gap and remove the black tendon. Luckily, with an Achilles injury, usually responds to treatment. We don't have to see them in the office very often unless that heel's involved. You'll typically see a complete response within 3 weeks. If it's a little bit more involved, especially if they have a little bone bruising in about 6, and you can be progressive with your activity. Anybody with the exams weird, like it was for me, even if you're doubting your exam, a palpable defect, a ton of swelling, any redness or warmth, sometimes we'll have them get an infection of the bursa or the skin back there, and obviously not responding to treatment. Usually with these, there ought to be a pretty decent difference, even if they take 3 to 6 weeks to get better. There ought to be a pretty decent difference within 1 to 2 weeks. So that's what you ought to see with that. Probably more importantly for what we treat and what we see is the ankle sprain that isn't when they injure the foot, especially to the midfoot. Again, pain with weight bearing, we're probably going to x-ray anyway, one way or another. But a midfoot injury can really lead to some chronic problems that not only bother them in sports, but bother them the rest of their life. Midfoot sprain is named after a surgeon, Liz Frank, who was Napoleon's Surgeon General of his armies, who described it in soldiers that were getting knocked off their horse with their foot stuck in the stirrup. Back then, whether it was moderate or severe, the treatment was amputation. Right across where that blue foot is. So we've got some better. I scared the hell out of the kid yesterday by telling him that he didn't want to use crutches. So, but the mechanism is it can be a direct crush injury to the foot. Usually, what you'll see, what I saw in the kid I saw yesterday, who drove up from South Texas to see us, was he was playing basketball Tuesday night. He was planted. And then someone stepped on his foot, and as he was right foot trying to go left, his foot didn't go anywhere. And he felt 2 or 3 pops. The pops are usually pretty common, and he was done. He couldn't do anything at that point. I think they tried to get him to run and play after that because he was a point guard. And initially, the coach got mad at him because he couldn't even inbound the ball. But these hurt. And in his case, he wasn't fractured or even this bad. This is a surgical one. But these hurt like crazy. Indirectly, what you'll see is they'll be fixed and it'll be plantar flex, and it'll be the rotation, so they don't have to have the direct crush injury. Which makes this such a bad injury is that this is the arch stone of the 2 arches of the feet. We're used to our longitudinal arch with our plantar fascia. There's our transverse one as well. And once we lose this, we lose a lot of support on the feet. It changes the way our big toe, our first toe, and our second toe bear weight. Push off, it changes the way we rotate, so to push off and change direction, and it'll collapse with time, so just standing there hurts. You get to the point where, unless you treat it right, even the ones that are not this bad, they're going to hurt the rest of their life. And that's what we're trying to do to get them better. These you refer whenever there is any midfoot tenderness, especially with pain with weight bearing. I gave you kind of a classic example of couldn't even inbound the ball, so that was pretty easy. Sometimes what you'll do is be suspicious for it. It might be a milder sprain, a grade 1 sprain where they don't need surgery, but they still need to get off that foot for a while and be in the boot. So anything isolated to the midfoot, you'll see that. And especially if you have midfoot bruising, and I'll show you a picture of that somewhere in here. Midfoot bruising is usually used to at least get them x-rayed and get them evaluated. Depending on how bad the sprain is, we will MRI them or CAT scan them depending on what's needed. Here's a real good picture I found of an isolated bruise. These are usually about 2 or 3 days out. These don't happen immediately. But if you look at the bottom of this person's foot, obviously because the bruising is dependent and it bled into the bottom, it's really isolated to the middle part of that arch. You don't see it come anywhere near the heel or the forefoot, the ball of the first toe. And so these usually, when they hurt, you barely push on the midfoot, they hurt a lot, you turn the foot over, spend a couple days, they have this. It's a midfoot sprain no matter what. We're x-raying them or MRIing them to see if it's grade 1, grade 2, or grade 3. Even the grade 1s are not in weight bearing traditionally for a while, and most of those will take a minimum of 6 weeks to get back. The grade 3s will take a lot longer, the grade 2s anywhere between 6 and 12 weeks. So these are major things where you can really improve somebody's life. Now for the big toe injury, because the big toe involves most of our glad to see some of you guys know what I'm referring to. If you don't, go look it up on the internet. Big toe bears 40% of our weight, but without it, for people that have had great toe amputations, when you do it, one thing they lose is they have a less efficient gait that causes more and more problems up and down the chains of the leg and the back. They definitely, from an athletic standpoint, although they can learn how to run, and we'll put a prosthetic in there to fill that area so they can push off, they just don't have the same speed. And even when they walk, they shorten their gait. It just changes everything. And again, can affect the chain going up into the back. When we're talking about this area, we're also talking about sesamoids, the first joint, the metatarsophalangeal joint, and the first metatarsal itself, the bone going into the midfoot, also known as the first ray. These, especially with any deformity, you want to get looked at. And on that outcome comes into that it's involved in push off. And it's the most important part of our foot. It not working well affects everything we do in normal life, much less in sports. Differential diagnosis can include a sprain of the main joint of the toe. Usually what we get with a stubbed toe, you can have inflammations of the tendons around the sesamoids without the sesamoids being affected. That's good with sesamoiditis. You can actually have the sesamoids affected where they're bone bruised and they have a stress reaction. Or worst case scenario, they have ABN. ABN when the blood supply dies out because of chronic injury like you would get in chronic inflammation or chronic repetitive use when these hurt. That can lead to chronic foot dysfunction as well. The only surgery I know of for ABN of the sesamoids is removing them. And some people that we treat want to have that done, but I remind them they're there for a reason. 50 years ago, we used to remove kneecaps for chronic kneecap problems, and that's all those people out there doing. So the same thing, their x-rays look weird, by the way. And so the same thing with the sesamoids. We try to leave them there alone. But people such as my brother-in-law, who's had one since he was at Madison, way before Jason and Tim were at Madison, affects the rest of his life, affects the way he wears shoes, not able to run anymore, and so forth. Can also be a turf toe and a fracture, and we'll go into those here more right now. A turf toe is essentially a glorified sprain of that first joint.